Series. I'm Laura Holdsworth from the Evaluation Sciences Unit, and it's my pleasure to facilitate today's lecture with a very good colleague of mine. But before we get going, just got a couple announcements. So firstly, the early bird registration for the LEAN conference, which will be in September, is now open. So please consider registering to join us this fall. The second announcement is that the Lilly and Donnelly seed grants are now open, I think, with a due date for the first round in July. So more information is available on the website if you're interested in applying there. Well, great. Well, so today's speaker is someone who should be very familiar to most of us. Dr. Cati Brown-Johnson is a senior research scholar in the Evaluation Sciences Unit here at Stanford. She is a trained mixed methods health services researcher, social scientist, and implementation scientist. Her content areas have been quite varied, but she is particularly interested in bringing the voice of patients and stakeholders into academic research, and especially including underserved groups in research. And that's what today's work will center on, about increasing diversity in clinical trials, which she presented recently at a conference in Amsterdam, I think only last week. So if you have any questions, please feel free to put them in the chat and we'll save them for a discussion at the end. And with that, Cati, please go ahead.
All right, let me share my screen and see if that, this will work. Great. Do you see?
Yep, that looks good.
Awesome. Okay, and let me make all of you big enough. I'd like to be able to see y'all and the comments at the same time. All right, cool. Here we go. Fantastic. Well, thank you so much for inviting me to represent Total today. This is the trial of sites to increase diversity in clinical trials. And I'll be chatting with you today about including underrepresented patients in cardiovascular clinical trials. Many of my Total colleagues are on the call today. Thanks for coming to support. Feel free to put questions in the chat or for my colleagues to put clarifications in the chat if there's something that needs a little more explanation. Total, just as a little bit of a background, is a collaboration between Stanford and Morehouse School of Medicine funded by the American Heart Association. And it's a trial of trials where we're randomizing cardiometabolic trials to diversity enhancing recruitment strategies. And in doing so, we hope to investigate the facilitators and barriers to improving diversity in clinical trials. And for this talk, you'll see, but I'm quite focused on racial and ethnic diversity. Laura introduced me, but like she said, I'm a senior research scientist with the Evaluation Sciences Unit. I'm an implementation scientist, and like she said, very passionate about including patients, clinicians, and scientists' voices in medicine. And I have no conflicts of interest. So here we go. But my mouse decided not to work. Okay, so why is inclusion important in clinical trials? This is really about, some of the risks originating in the lack of inclusion. So, without attending to inclusion in clinical trials, there's really the risk of compounding health disparities that already exist. That's, at the scientific, at the medicine level, for clinical trial lists and clinical trial organizations, there really are, these risks around sunk costs related to low accrual. And we'll talk a little bit about a rare disease where that can even be, more problematic. And increasing inclusion is really a potential way to increase accrual. And then there's also possible regulatory rejection. So the potential to get all the way through a clinical trial and then have it rejected, or have the FDA, the US FDA say, no, you've got to go back to the drawing board. And that's happened within the past 5 years around Alzheimer's drugs. So this is an important piece of how we include patients in medicine. There are many different aspects of inclusion. So I'm focusing on race and ethnicity for inclusion in this talk, but I just want to go over, many different aspects of inclusion that can be static or changeable. And some of these examples including all genders, thinking about ability and disability, including neurodiversity, thinking about race and ethnicity, of course, and that can be closely tied to language and even transitional states, such as pregnancy. When I think about inclusion in clinical trials, what I think about is, how do we address this? What are 3 things we can do to increase inclusion in clinical trials? And there's good news and bad news. The bad news is that the lack of inclusion really starts way before recruitment for trials. And at least in the US, it's tied to access to healthcare. It's tied to earned mistrust of the healthcare system, and even more broadly to systemic racism and oppression. Some of this is really all the way back due to US history of colonialism and enslaving people. And it's really potentially compounded by our privatized health system. So the bad news here is that there's really no silver bullet that is going to magically fix inclusion in clinical trials. I do want to propose though, so the good news is that we have some good strategies that are being tested, and we'll go over those shortly. And in addition to presenting these strategies, I also want to share with you thinking about a learning clinical trial approach. So this is an image that's really focused on learning health systems, which you're probably familiar with, that are really driving clinical systems to think about how evidence, data, and practice can inform each other. Applied to clinical trials, I'm thinking this just might look something like this, something very similar, where you can apply evidence, how evidence, data, and practice inform one another to a learning clinical trials approach. And I'll share with you a bit about how I'm thinking about that. Really, for me, it's about applying the Lightning Report approach. It's work that I piloted and fine-tuned here at Stanford with the evaluation sciences unit. And then we've applied it with Total to help us learn and adapt our strategies as we go along. We'll go over it more in just a minute. But I wanted us to take a detour to get a sense of what diversity in clinical trials really looks like. And I'm just, focusing on one rare disease. This is pulmonary hypertension. This is a rare disease. It primarily affects women. I think it's 62% of the patients are women. And it's really a rare disease. It's like, 50,000-ish people in the US. This data is really hot off the presses. It's a review of racial and ethnical diversity in US pulmonary vascular clinical trials. So first off, 18 of 56 studies didn't even report on race and ethnicity. And what I've highlighted here are just a few things that I wanted us to look at. In yellow, you'll see numbers that are way below what the representation is in the US. So just to go through it, within the clinical trials, there were 4.2% of patients were Black or African American, compared to what's next to it, the US percentage is 13.7%. There were just 0.5% American Indian or Alaskan Native, and that's compared to the 1.3% of the US population, and then 0.1% that were Hawaiian or other Pacific Islander. compared to 0.3% of the US population. And another group that was quite low as well, or lower than the percentage of the US population, was Hispanic or Latino at 15.9%. This is in blue, compared to 19.5% of the US population. I did also want to point out, this is from 2020 to 2024. And within the Asian and Asian American category, 19.3% of the clinical trial patients were Asian or Asian American, compared to just 6.4% of the US population that's Asian or Asian American. And I just want to thank the total trainees and Dr. Paul Wang for pulling this data together really within just a couple of days. And so this is the overview of the study design for total. And really our goal here was to put these side by side, refine, test, and evaluate these diversity enhancing clinical trial approaches. And so just to go over them briefly, there's the community-based approach that's really about community ambassadors. We have a registries approach that's working with study pages and a few other research registries. There's a social media approach that's really focused on culturally culturally relevant ads. And then the control is just usual recruitment protocol. And the total team really doesn't interface with participants for any of these interventions. And what we've layered on top of this is the Stanford Lightning Report approach. So Total also provides lightning reports so that we can understand more about what is working for a recruitment strategy and what possible modifications we might need to make even as we're going along with this trial. So the lightning report, just taking a step back, this is a rapid qualitative approach that I developed with the evaluation sciences unit. And depending upon the data collection, our team can turn around a report for a site in about 24 hours, which is just really unheard of in qualitative research. And so I just want to highlight the three main parts of this. It's really the executive summary, and you can think about that as like the smallest abstract ever if this were a paper. There's the data collected, which is really, again, the smallest methods you're ever going to run into. And then findings, and these findings really focus on lean categories of plus, delta, and insight. So what's working, what needs to change, and what insights we have. And I just think that the setup within Total is pretty innovative, where we are doing lightning reports, quality improvement lightning reports, interviewing clinical coordinators and PIs. And that's nested within the research that is looking at the different strategies side by side. Does this include honest broker outreach? I think honest broker outreach lives within the research and study pages. I would invite the rest of the Total group to chime in on the chat if I'm wrong about that. So let's kind of go through each of these, what really each of these strategies looks like, and then we'll talk about some lightning report results. So the community ambassador, this is really connecting, this is a person who is connecting the trial team to organizations and service providers. I think what's innovative about this position is that this is a person who is remote, but finding referrals and opportunities locally. And from our theory of change standpoint, how does this increase diversity? This is really a unique opportunity to outreach to leaders and organizations that have personal connections to underrepresented groups. So our second strategy is registries and study pages. We'd mentioned already study pages. We're also working with Research Match with the UCSF Care Registry, which is an Asian and Asian American registry, and then a Stanford registry that's just internal. And then we are also looking that, the final active intervention arm is really around social media. And this arm uses Facebook and Google ads to promote the study. This is done with IRB approved, culturally tailored ads, such as the ones on this slide, and is really in partnership with Build Clinical. And I'll just say, because I was presenting this in Europe last week, Build Clinical doesn't work in Europe, but there are other social media clinical trial supports, like TrialB in Sweden and NATO in France. Like this is something that, if it's not crossing borders, is available in many countries. And so what did we find in terms of the Lightning Report findings? What we really saw when we've interviewed staff, interviewed the clinical trial staff and the PIs, the feedback on the community-based, or the community ambassador, was it really helped to reach candidates outside of the university's typical pool. And then the upside downside is that the groups that were reached really were about the personal and professional connections of that community ambassador as an individual. So it's not necessarily about reaching out to a wide swath of folks across different race and ethnicities, but really kind of digging in based on the affinity groups that community ambassador is connected with. From a registry standpoint, we got the feedback that these were user-friendly platforms. It really was helpful when the registry teams could take on some of the recruitment tasks, basically take some of the lift off of the clinical trial staff. And some sites noticed increased diversity, but they kind of also had hoped for more. And you'll note that our trial is not done, so we are looking at recruitment numbers, and I'm not presenting those to you now because we don't have our final numbers with that. Social media, we found that Build Clinical was quite good. They pre-screened candidates and yielded a really manageable volume of eligible candidates. I will say our Lightning Report approach early on did uncover a really big hiccup with our social media approach, where we were not partnering with a group that did this as part of their usual work. And it really backfired in terms of, you could reach a large number of people through social media, but then the volume in terms of screening for the clinical trial staff was really not manageable. And it didn't convert to people who were eligible. Basically, it was just too much of a shotgun approach. And so we within the intervention arm of social media, we shifted a bit to really focus in on Build Clinical to be able to address that issue. And then we have also talked to folks in the control group. Really, this is about physician referrals that are emphasizing provider-patient trust. But what we do here is that this quickly exhausts typical patient pools. And this is part of the reason why why we eventually added a delayed support for the control arm. And so broadly, what factors did we see that support diverse recruitment regardless of strategy? And they're really factors kind of at the systems level. I think of these as system level factors. So clinical research coordinators and PIs called for centralized funding and recruitment support. And some of that had to do, with budgeting ahead of time to account for diverse recruitment. So particularly for trials that needed to use, that were charged for each IRB modification, thinking ahead of time, budgeting ahead of time for the IRB modifications needed, for instance, for the different tailored outreach, the social media outreach was something to think about. And I would propose too that trial teams really can consider a combination of recruitment strategies, and even think about using the Lightning Report, and using a learning clinical trial system to examine within a trial, which strategy is best aligning with study design and capacity. And I also think, this is what we're doing with Total, but I do think that we can think about continued refinement of recruitment methods really across clinical trials as part of a national or a regional learning clinical trial system. So here's my invitation. If you're interested in participating, if you are running a clinical trial and you're interested in participating in the Total trial of trials, we're looking for cardiometabolic trials. If you're at Stanford, we have probably reached out to you, but we would be happy to chat with you again. And that's the diverse network at stanford.edu. You could also reach out to me and I can route you in the right place. And then also, if you're interested in partnering with the Evaluation Sciences Unit on a trials learning system or on embedded Lightning reports within your trial, I would be really happy to chat with you about that. And I'll put my my email also in the chat as well. And I just wanted to end with this image of the learning health system for clinical trials. I'd love to chat more with this group about what we could do, or what this learning health system for clinical trials might look like. I think they're literally like 2 publications on the topic, and no good visuals yet. Like, this is one that I just through the learning clinical trials circle over what we've got there. I think there's a lot of work that we can do in this space. So I will pause here, but I'd love to get any feedback or chat more.
Thank you so much, Katie. That's super interesting. I'm sure everybody would join me in a virtual round of applause. Thanks so much. If anybody has questions, feel free to put them in the chat and I can read them, or you can raise your hand and I can call on you. But I can kick us off. Katie, I'm really interested in what your sense is about whether there's a particular strategy that's best suited for either a population or an intervention type or an area or ecosystem, specifically thinking about Stanford. Is there one kind of approach, if a trial had to pick one, what's the, how do you go about picking one? I know you mentioned you could use multiples, but what's your sense about the kind of fit of those strategies within a particular context?
I love that you are writing my research question for the paper on this. I would say, the community ambassador is one that, if you were looking to target a specific group and really boost your numbers, and boost your enrollment and inclusion with a specific group, and that was really your goal, I think that community ambassador would really be what I would lean into. Again, because of the both the great aspects and the limitations of that role in really focusing in on that. I think you could also, apply that same principle or process if you're looking at including, if you want to include specific languages. Like that would probably be a good support. Tenzin, I'll just invite you. Tenzin's been doing interviews with me, and in fact, leading interviews that I'm not always available for, I would just invite you to chime in, Tenzin, if you have any thoughts on this. And it's fine if you don't. We haven't actually looked at the data from a like a matching, you know, what are the factors and what might match well with a trial. But like I said, I love that as a research question. Tenzin, do you want to chime in?
Yeah, I'll echo some of those thoughts. I think we're still looking at exactly like what works best for specific populations and trials, but I will say overall from the interviews, I have been noticing that people are like really enjoying the fact that there's a boost in their participant numbers, and they do say that it's fairly easy to implement these strategies. So that's just something I've noticed overall from the interviews.
Great. I'm curious about the PIs, and I know that, I mean, I believe trials were randomized to a strategy, and I don't know if the PIs were aware of the other arms. Have you talked to them about, you know, the other strategies? I'm just wondering what kind of input, or, you know, if they've said, oh, this is something I would do again, or they wouldn't do again. Yeah, I wonder how aware they are of the other interventions.
Yeah, so they do know that the other interventions exist before they're randomized. That's part of our recruitment, is look at all the cool stuff that we might be able to support you with, and I think that's part, you know, that's part of the reason why we added a delayed support for the control arm, because we did hear we heard a couple of interesting things from folks in the control arm right off the bat. And one was that really people, you know, at least the folks who are opting into this trial of trials are really committed to increasing diversity and inclusion, and really, you know, looking for ways to do that already. Again, within the umbrella of, you know, what's available in terms of the trial resources, you know, because I think the best example of it being kind of a bigger burden than expected, to try and do greater inclusion, was really with the initial social media, which we're not doing anymore because we're working with Build Clinical, just in terms of having lots of people to vet that then don't, that aren't eligible for whatever reason. I have lost my train of thought. Where was I headed with that, Laura?
PI preferences, I don't
Oh,
know.
yes. Yeah. So, you know, we have heard, I mean, it, part of why folks are getting involved with this trial is because they're interested in the different arms, and I think that's a great question. In our, you know, a lightning report approach is meant to be pretty short interviews with people, and so we haven't ask folks about their perceptions of the arms that they're not a part of. But I actually think that could be, so we're talking to people when they enroll and at 3 months and then at closeout. And so that I think is something that we could chat with people more about. And I would just invite anybody that's part of our team to chime in if you want to add anything. It's a great question. I did see something in the chat, the Progress Project with Beth Darnell. Ting, did you want to chime in on this? Has a paper, yeah.
Yeah, I don't know if you know about us, but I've been involved with Beth announced the second. This is the second PCORI funded project, and this particular one actually we try to, because PCORI is really pushing for inclusiveness, and so we actually have a patient advisory board that actually include, you know, Hispanic and various ethnic groups and so on. So that, yeah, has done quite a bit on, and there's a paper actually came out that actually have been talking about the results, and so far the trial is still going on. I think the recruitment it's getting extensions also. You may want to contact there to know the status. The other thing I'm curious is actually because PCORI also has the funding for science of engagement. And I think your project probably fall exactly in that category because everybody is looking at different way of doing engagement. And there's no sort of concrete way because, for example, clinical trial all over the place. Certain clinical trial very specific, but other clinical trial is more, say, for example, longitudinal trials are very different. So I don't know if there's a one way that fits all requirement for inclusiveness. For example, I've been involved with somebody from UCLA looking at why elderly, Hispanic, and Asian population do not, get in like to join clinical trial, and a lot of the issue is sort of cultural, not so much language. Of course, there's an issue, but also sort of cultural background, especially for newer immigrant elderly. There's a paper that actually she came out on particular for the Chinese elderly community already. I can send it over to you. I think it's a very interesting. It's funded by FDA actually. It was actually Mimi Tan from UCLA and
Yeah, please,
Schwartz from UCSF. I can send you the paper. You can
please
take a
do.
look at it also.
Yeah, please do that. I mean, I think this is looking at the different approaches is kind of one slice with this. Another, a different way to think about increasing inclusion and increasing diversity is to think about sort of what are the drivers for different groups. And I know I've seen within the Asian and Asian American community, and this may be the case for other groups as well, but it's just something that I've seen specifically in that research that the messaging or framing inclusion in trials as giving back to the community is a big motivator. So this is really a trial. Total is a trial of strategies, but another way to think about increasing inclusion would be to think about a trial of motivations or a trial of communication approaches, sort of different levers. Altruism, is this, this is for your family, etc. Like what are the different messaging approaches that might work for people in addition to sort of the channels that you're recruiting through. I do want to invite folks from the Total team to chime in if there's anything anybody wants to add. Nicholas, I see you might be coming on video. Do you want to say anything?
Yeah. I just remarking on just on Ting's comment about the PCORI grant and about progress and how Total, and as you could probably see in the comment that Catherine was working on is TIDE, which is another one of our projects that's under Diverse Network Center. And I think this is really helping to inform, both of these projects are really helping to inform where we're going to go beyond here, beyond where this AHA funding that we have, and how we can progress through this. Because, I think one of the important points that comes from a lot of this work, and this is kind of a broader context for things about how we navigate this environment, about especially for what is the most efficacious for clinical trial strategies and recruitment, is navigating this environment since, anti-DEI orders, changes in the environment in terms of, sponsors, not having real guidance from the FDA as to submitting the DAPs, which are kind of still waiting for guidance in this time period. And so I think beyond here, what the aims are from a lot of this and how it's going to inform a lot of the future work is, we are looking toward proposing a focus toward the community-based function. And so, a lot of the work that I'm trying to do with our center director, Dr. Eldrin Lewis, is to possibly look at ways that we can engage community-based organizations to fundamentally help to champion some of these strategies that comes from a lot of the data that's going to be coming from total and tight as well. So I think this is take a step back, Katie, great presentation. But I think a lot of this is very pivotal for how we're going to move forward, especially with this kind of work from Diverse. So
I really appreciate, thank you so much for that, Nicholas. Yeah, and I'll just say, having presented this in Amsterdam last week, one of the pieces of the conversation that I thought was really interesting, was some concern or interest about, the variety of care that people get across the U.S. and kind of, I was thinking about it in terms of the difference in care between states, but also, just the difference in care between folks who, have Medicaid and Medicare, and who have private insurance, which I really think of as being very different from what you see in Europe, where there's more socialized medicine. But I was really interested in that conversation to hear about kind of the differences between countries. So there is socialized medicine across Europe for the most part, but there are differences in terms of what is approved for people and within what timeline, that I just hadn't really been aware of previously, or I hadn't thought of. In I was thinking about it more in a monolith. Anytime you go and visit someplace, I feel like you'll see a little bit more about the nuance. I know I'm rambling a tad, but I just thought that was thinking about inclusion and about the impact of our changing landscape. I think it's really important. I'll pause there. Go ahead, Laura.
Yeah, I was just gonna have, so given that the changing landscape, I was just thinking, what are the outcomes of the trial itself that you're looking at, like the sort of trial outcomes? Because I think that, obviously, more diverse populations is the one, but, just thinking about maybe time to recruit, and there might be other, outcomes of the trial that would benefit, right? We just heard from Chris Liu a few weeks ago talking about increasing access amongst Spanish language patients, and that means she can recruit faster. So I'm just wondering, like, what are some of the other trial outcomes that you're looking at that aren't just sort of about the diversity outcomes?
Yeah, so we are looking at diversity outcomes. Victor, if you're at a place where you can chime in on some of the other outcomes, because that's definitely, I'm more focused on the Lightning Report side of things. Yeah, do you want to chime in?
Yeah, sure. Thanks for great presentation, by the way, Katie. Yeah, so we are looking at a few things, all around diversity. So proportion of Hispanic non-white participants, and also we do have two important distinctions we have is how much those strategies kind of move the needle in the final number of participants enrolled for each one of those diverse groups. However, there is another we should worry about if those strategies are being effective, all the way until the finish line. What I mean by that, like it doesn't particularly help a clinical team if one of our strategies just floods the clinic with patients and none of them are eligible or, of particular importance to your trial. You're just going to, overburden your clinical team and, and it's not going to increase your enrollment numbers because you really brought the wrong participants to, through the door. So our secondary, one of our secondary outcomes is, this conversion rate. Okay, how much our strategies are increasing our screening numbers, meaning patients through the door or, patients that are potentially eligible, and how much of those are actually, being converted to an actual patient. Because, we want to understand that too. Like maybe for some trials, it's good to have more patients come in than others. Also, of course, depends on the clinic's infrastructures, and every trial is different. But I would say that's our secondary, outcome, also important to look at, because we don't want to just, flood the gates with participants that are not relevant to the trial. So we want to be efficient.
Yeah, that's great points. It's not just getting more people, it's getting the right people.
Yeah, exactly. Yeah.
All right, I think there's one question in the chat.
I can chime
Katie, do
in
you wanna-
about that.
Yeah.
Yeah, I was writing you back, John. Yeah, this is a great question. Why did we use the US Census as the benchmark for diversity versus the Bay Area or some other benchmark? And it's really, it's a great question. It really is an artifact of presenting in Europe. I was wanting to talk about the U.S. overall and have it be a comparison between the trials in 2020 to 2024 in the U.S. I think we could benchmark it against the percentages, what it looks like within that particular that particular rare disease. And that's actually part of the reason why I didn't include the data around genders, because because there is a very good representation within pulmonary hypertension trials of women. And part of that is an artifact of the disease, which primarily impacts women. So, I think in writing this up, we would want to benchmark it against the US prevalence rates for various race and ethnicity. It's a great point. But I was just thinking about, helping people in Europe be able to understand what our benchmarks are at a national level.
Thank you, Katie. If there's no more questions, I think we can wrap up. Thank you again so much for your presentation today. Really very interesting. And I hope everybody can join us again. Yeah, round of applause. Thank you, Lisa, for that. And I hope everybody can join us again. July 8th, we'll be having Katie Smith from our PFAC, which kind of feels like a nice kind of follow on from this, thinking about engaging patients and family in various different QI and research ways. So thank you very much, Katie, and I hope to see you all again on July 8th. Thank you all
so much. And thanks so much to the Total and Tide teams. This is definitely, I hope it's a useful representation of their work. So thank you so much, everyone.